you want me to hang on a bit?
Okay, it started now. Sorry.
Great. Okay. So the agenda is going to be, we're going to have updates from Rachael Swift about her mobile unit work in Stoke, then from Dr Sharon Raymond about the Crisis Rescue Foundation Medical School. Then we'll have the updates from the faculty subgroups. We'll have talk about the recent work around the NICE guidelines. We'll have some feedback from the conference, and then your chance to feed into any ideas for themes or sessions or people to appear at the conference next year, which will be next March. Alex is going to talk about the members survey, and then we're going to have a little talk about the recently produced Pathway Shared Health A+E training. So I will copy and paste that again into the agenda now that a few more people have arrived, but just so you know what's going on. Okay, so we'll kick off with an update from Rachael Swift from Stoke about the mobile unit. And I know Rachael is around because I talked. There you are.
Thanks, Chris. Yeah, it was just basically to touch base with you guys and obviously make a little introduction of myself and the team and what's kind of going on across Stoke-on-Trent and Newcastle. Just to give you a little bit of background, I came into this post as an advanced nurse practitioner for homeless healthcare last March to April time. But prior to that, I'd worked down at the University Hospital North Midlands for about 18 years. 5 of those years, I helped to set up the alcohol liaison post in and around A&E. And then the majority of the time, I've been kind of a nurse practitioner, but mainly in and around acute medicine. So that's kind of my background. And then the existing AMP, Jane, she kind of reached out to me last year and said, is there something that you'd kind of be interested in doing career-wise? And I was like, yeah, absolutely. So the rest is basically history. So just to give you a little bit of an overview of our service, I mean, it's been ongoing for many, many years. Jane's been around for quite a long time. She's like the matriarch of homeless healthcare currently. In 2019, obviously all the things changed. The GP Federation, North Staff GP Federation, won the bid. So of course the service went to them. My role started last year, which meant that I could start cross-covering across Stoke and Newcastle, because historically all the kind of homeless healthcare was for Stoke-on-Trent. So there's kind of 2 entities, Stoke-on-Trent and Newcastle, 2 separate authorities that work quite differently. So I can kind of cross-cover the 2 areas. And then recently we've had funding for a 3rd AMP, which is based down at the hospital. It's a full-time role, but because obviously I've got the links with the hospital, I've taken a little bit more of the lead in and around setting and implementing things down there, which is why I reached out to Chris, just to try and get some insight around the pathway and, you know, how things work, and obviously can we spend some time with Chris in July time. So there's quite a lot of things going on at the hospital, lots of meetings and things like that. And I'm trying to obviously implement the pathway, not like for like, but obviously I've had to tweak things a little bit. I think there's quite a few sticking points in and around safeguarding, seems to be the main one at the minute. So yeah, that's the hospital side. So as I say, there's quite a lot of layers to the role. The mobile unit works in and around Stoke-on-Trent and Newcastle. So it's any kind of GP related problem, and we take the service obviously to hotspots that are known areas where we know homeless patients will be, and we try to get to each area at least twice a week at the same time, so that obviously, you know, the patients will know where we'll be. Majority of the work, I'd say, is quite heavy at the minute on wound care. Monkey dust seems to be our biggest nemesis in and around Stoke-on-Trent, way more than heroin, alcohol. It's quite it's a real nasty drug, and there's not a lot of research into it. It's just obviously known as a psychoactive compound, and I think they are on about obviously with the laws and things that are ongoing at the minute, is classing it as a Class A drug, but that is kind of our biggest nemesis at the moment in and around the streets. So we provide an in-reach at the hospital, outreach obviously, we're out and about 5 days a week, we're a 5-day service at the moment. So yeah, that's pretty much a bit of an overview of the service. We're a non-profit organisation as well, so any money that is generated will obviously go back into the service for the patients. So in a nutshell, that's us. Like I say, I wanted to touch base with you guys and just kind of put us on the radar and take some of your fantastic practice back to our hospital, and hopefully start making a little bit of a difference. There's such big gaps with the discharge processes for homeless patients, so much so that kind of the feedback on the wards is that every ward is dealing with things just so differently, so there's no kind of standardization of care whatsoever. So it's a big chunk of work, but I think obviously with time and the right people on side, and getting the kind of document through governance, then hopefully, fingers crossed, we can start to try and make a little bit of change at the hospital. So yeah, that's kind of, like I say, a bit of a whistle-stop tour of our service. I'm conscious, obviously, I don't want to take up too much time. So yeah, thank you for inviting me.
You're welcome. Thank you. So do you want to just tell us a little bit about what sort of typically happens on the outreach? What a kind of outreach day or outreach morning looks like?
What we tend to do is we work in partnership with Brighter Futures. So the van is owned by Brighter Futures, but it's kind of contracted to us for, I think it's 30 hours a week. So on an outreach day, we'll all kind of meet at one location, which is usually one of the hostels. Any names or kind of contact details, they've got it's a bit like a database that the public can ring into, leave either a name or a contact point or a location, and we go out and try and find the patient, verify the patient, and obviously get them into the system and start working with them.
Great. And what are the sort of typical things that you're seeing? I know you said you have a lot of problems with the
I mean, monkey dust is the biggest, and obviously with that, we work quite closely with the addiction services. As there's no kind of, the thing is, obviously with heroin, you've got your substitute drug you can use, but with monkey dust, it's very difficult to manage, especially when they are intoxicated at the point of the assessment, because it's so unpredictable. I think the thing is, one person takes it and reacts completely different to the next person, and there's no antidote either. And the wounds are quite significant. I'd say that they're all kind of having the same type of hallucinations. So lots of visual hallucinations, and they're thinking they're seeing little tiny bugs crawling out, and they're gouging and they're pecking, and obviously introducing infection. So yeah, lots of nasty wounds, abscesses. Stoke-on-Trent is probably renowned for, obviously, with the pot bank. So you see quite a lot of COPD, especially with the older people if they've worked on the pot banks. We do a lot of signposting to the sexual health clinics as well, especially for obviously females. We've got a mental health worker as well on both sides, so as if we feel that they need assessing, then we can pull them in. There's been a couple of patients that have had to be sectioned as well, so it's probably it's very different, into every day is never the same day, so lots of different things.
Sure. I don't know what a pot bank is. I don't know about anybody else. I know it must be something that's quite common around your way, but
so lots of like where they make plates and cups. Roald Dahl, Royal Dalton, Wedgwood.
Yeah,
those are like the famous pot banks. So you'll know if you know a pottery person, because they always check the plates when they go on holiday.
I was confused when you first started, because I'm just outside Newcastle. But I'm not the same Newcastle, obviously.
No, no, definitely not.
Yeah.
Yeah.
So, and then you're obviously
sorry.
So I did wonder, because it's a bit of a trek to Stoke-on-Trent from Newcastle upon Tyne.
Definitely. We have to double check things for Newcastle, just to make sure it's not the one up north.
Thanks, Rachel. Any questions or anything or comments from anybody?
I mean, it sounds amazing, Rachel. It sounds pretty tough. I guess there's Alex Bax here from Pathway. Just wondering, to get the question we often find ourselves worrying about: where do you get your money from? It's the NHS. Are you a commissioned service?
Yeah,
are you self-funded?
So lots of different pockets of funding. So, for example, my role is funded by Newcastle Council, Stoke-on-Trent Council, and the CCG. Then the other AMP, she's just Stoke-on-Trent Council, and then the third AMP, there's an organisation called Changing Futures. So they've funded the third role, but that again, that's a 12-month thing. So we'll have to obviously see where we're at, which is why I'm quite conscious to get things going at the hospital.
And when the vehicle is funded by, I think you said the charities provided the vehicle.
Yeah.
And things like, what about clinical governance and those kind of, I mean, are you,
so that sits
do you
with
feel
us.
supported?
Yeah, that's obviously the clinical governance side of things sits entirely with the GP Federation, which are our employers.
Right. Interesting. And do you feel supported by them? Do they know what you're doing?
Yeah,
I mean, do they?
Yeah, I mean, the thing is, I think with the healthcare side of things, we're very much nurse-led. I mean, if we've got any kind of queries or anything, I mean, like I said, Jane's very, very knowledgeable clinically. But with the things like the funding, that tends to be Ian, the kind of operational manager, and then we've got a clinical lead, Gareth, as well. So we get lots of support. I wouldn't say that I'd feel under-supported in any way, no.
I guess the other thing, which isn't new to me, I guess, is I mean, I've heard of monkey dust, but haven't heard someone talk about it as being such a dominant thing.
Yeah.
Interesting. We have seen over the years how different places have different drug cultures to some extent.
Definitely, yeah. I think Stoke-on-Trent is now known as Stoke-on-Dust. That's how bad it is.
Do you know why why there particularly? Why, I wonder why it's landing with you particularly.
Well, I mean, I suppose the epidemiology, I don't know what you want to call it, but I think, I mean, it's cheap, and I think it's manufactured in and around Stoke-on-Trent. Kind of word on the street is that it's coming from such and such a source, so I think it's being manufactured locally as well.
Right, interesting. And of course, sorry, last question. And what about in terms of the drugs world? Do you have close working with them? Are there people?
Yeah, definitely. I mean, we're all kind of trained in giving, Narcan, and it's the addiction services that provide that training for us. Yeah, I mean, like I say, we're quite close knit. I mean, probably the Newcastle side, as I say, that works a little bit differently, but I'd say, 9 times out of 10, if we give them a call, they're straight on with things.
I guess for new narcotics, it's what harm reduction is sometimes quite
really
hard to
difficult.
Know, isn't it?
Yeah, really difficult, and it's just a different beast. And I think, historically with heroin, you get those, the traits, don't you, where they're really sleepy and, they're leaning forward and they're gurning. But with the monkey dust, it's so, like, I've never seen anything like it. It's just so unpredictable from one person to the next. So yeah, it's not good. And obviously there's no antidote either. So if they do overdose and they've taken up 20, it's normally a case that they have to be sedated because of that, they're that risky.
Right. Well,
great.
Sounds grim, actually.
It is really grim.
Sound great. I didn't mean great about that. Thank you for presenting to us and telling us what you're up to and how things are going.
Thank you for inviting me.
Progressing really well. Okay, thanks, Rachel. We will move on. Next person is Dr. Sharon Raymond from the Crisis Rescue Foundation Medical School. Is Sharon around?
Yes, I am.
Great.
I'm
welcome.
Don't know if I'm going to be able to. I'm mobile at the moment, so you'll have to forgive me.
Do you want us to come back to you when you've got to somewhere better?
I'm okay.
No, you're okay to continue.
I'm okay as
great.
long as you can hear me, but I am outdoors.
I can hear you fine.
But that's okay.
That's fine.
So, where do I start? Okay, so I'm the director of Crisis Rescue Foundation. It was set up, I set the foundation up, it's a not-for-profit about, it was at the beginning of the COVID pandemic, about 3 years ago. Is it really 3 years? I didn't even know it was. Okay, no, it can't be. And we basically started up all sorts of novel services, initiatives. I don't know if you heard about the Vaxi Taxi project, going out vaccinating, thinking about inequalities of health and going out vaccinating, but also providing health and well-being support and signposting for people in homeless shelters, refugee centres, food banks, etc., etc. We've done about 40 of those pop-ups across London, and they've been very well received and had quite a lot of media attention and been commissioned by NHS. And last year I set up the fast forward to last year, where I set up the Crisis Rescue Foundation Ukraine Medical School UK elective program, which is a bit of a mouthful, but basically I was being approached by lots of clinicians. I'm a GP by trade, and I was approached by lots of Ukraine colleagues, who were suffering as a result of the war, people trying to access medical education and get some peer support well-being sessions. And so the medical school was born. It's, I think, the only online kind of offer of its kind. We've got a global reach, so we've got students who are both trainee doctors and qualified doctors getting support with their medical education, peer support, well-being sessions, battlefield medicine, and now not just Ukraine colleagues, but also Sudan and any other areas impacted by war and crisis. Lots of these clinicians are actually in the UK. Many of them are qualified doctors and specialists, in fact, and they're preparing for English exams and conversion exams to work in the UK. There's a huge group who are very interested in getting clinical placements, willing to volunteer, if it's kind of a health-related kind of service. And I think they could be a huge asset. Some of them are actually British and, born and bred in this country and have done first degrees here, but then gone to the Ukraine to continue those studies. And those studies have been interrupted. Some of them have qualified and are now doing exams to try and work here. So it's a whole kind of mixed bag. And there's a whole group of refugee doctors as well. And I think that, there's clearly a need, and there's a whole cohort that do need support and help, and I think that these individuals could provide some of that support and help, or at least assist in doing so. So that's really my focus today, rather than to talk about my health and well-being pop-ups, which I'm very interested in telling you about as well, but I don't want to overload you. But I don't want to be I've come on the premise that I'm mainly going to be talking about the med school and this kind of workforce, I suppose, this group of people who are really keen to find out more about how things work in this country, and are very skilled, very keen, and industrious. And I think that either as volunteers and perhaps in due course they could take on paid roles, but that's probably further on down the line. And I'm just wondering what people's thoughts are and how we can progress this.
So is it throughout the country? Are you looking for
Yes.
people nationally?
Yes, I'm looking for people anywhere. And I'll just say that at this point in time, we're in term 4 of studies, and we've got over 1,000 students registered. And that's bearing in mind they're not just in this country, they're also in lots of different countries around the world, but there are a few hundred here. Some of whom are registered, some of whom I've got separate groups with, and I'm trying to support with trying to organise clinical placements and support with doing exams here.
So what are the most useful things that people can do to help? What would be the sort of priority things?
So, I mean, clearly I think most of the people on this call are involved in delivering services, and you may have volunteers involved in those services. I guess it's about saying, do you have a need for more pairs of hands? Some of those pairs of hands being people who are quite skilled and have got clinical backgrounds. Some, we've got psychiatrists, we've got neurologists, cardiologists, GPs, all sorts. Okay, they're trained and have worked in a different country, but they do want to get that hands-on experience with service users and understand how the system works and, improve their English. Some of them have got very good English. But it just, it's a bit of a mixed bag. But I think it's just about saying, that perhaps there is a need and we can try and connect you up.
And again, sorry, I'm asking lots of kind of practical, probably quite stupid questions, but is it for people to come for a period of time, so for a month, or is it for people to be attached somewhere one day a week, or is it totally flexible from that point of view?
It's anything we want it to be. It's whatever I can offer, you know. So if you can give a clear offer, you know, what are the basic requirements, who you're looking for, what the area is, start dates, you know, frequency that someone would need to turn up, then I'm sure there'll be people who'll express an interest.
Okay, let's open the floor to other people for comments or questions. Alex.
I see there's a just if you can't see the chat, there's a message from Margaret Greenfield saying to get in touch with her medical school. But I was going to ask, so are these? I didn't quite understand. So these people are not currently registered practitioners in this country, is that right? But they may be becoming registered, or they're on the track to becoming a registered person. Is that right?
Sorry, I didn't realise you couldn't hear me. Yeah, they're all trying. A lot of them are refugees here. Some of them, you know, are British and have come back home. So it will be a mixture, but none of them, as far as I know, are qualified doctors. Although having said that, I think that there are some who've done their exams. They're refugee doctors. So we've got not just from the Ukraine, but from, you know, supporting a range of clinicians from different countries. There's some who are refugees in this country and have been for a while, have done all their exams and are looking for work. So they've also approached me. So I think that they're in the minority.
And a kind of related question, I wasn't quite clear. Do they want to be paid, or are they looking for voluntary roles? Which is, I'm afraid,
they'll be willing to do voluntary roles.
Right.
Obviously, you know, they've come here, you know, new to the country. It would be best if they could earn money, but they're accepting that as it might help them in their journey, you know, to working here, that an unpaid placement is also, I've organised about 50 unpaid placements, and some of those have led to paid work. So, you know, it just depends. It's exposure to the system. It's, you know, connecting with, you know, seeing how I guess, yeah, just being at the forefront of what's going on within allied services, you know, services allied to the NHS, because we work closely, you know, all the things that you're all doing are closely aligned with NHS services and improving their knowledge of the system and how things work here. I think that's, yeah, I think, you know, they'll be willing and happy to do things as volunteers, some of them.
Great, that's helpful. I mean, I can see you've put your.
Everyone, but
I can see you've put your details in the chat. So if people are interested in following up, they can get in touch with you. Is that right?
Yeah, that's correct. And I'll put the link to our website as well, so you can see the many and varied things that we do.
Thank you.
But
Peter,
we're all about inequality. So, you know, if you can get people involved in the line of work that you're all doing, it would be amazing.
Thank you. Peter?
I mean, I'm just thinking out loud that a lot of the existing pathway teams could probably do with extra pairs of hands. So if they wanted to volunteer while they were finding their feet here, then that might be a place that would be a win-win.
Amazing. Can you just repeat that, what you said, which service, Peter, because my connection's not good?
Yeah, the pathway homeless teams in the hospitals.
I think that would be amazing. That would be amazing. It would be really popular, you know, with these clinicians. So, you know, the sooner you can sort of, you know, tell me basically the nitty gritty of it, you know, when they can start, what paperwork's needed, etc. We can do like a flyer and you'll start getting applications.
Okay, and we can also put your details and the request in the faculty newsletter, which will go out to all the faculty members.
That's amazing.
Many of whom are in clinical services, so we'll do what we can to help. Any questions or comments from anybody else?
I guess just do they generally speak English?
Yes, all our lectures are in English. Yeah, majority of them will speak a high level of English, but you know, they also have other languages which can be really useful as well.
Great. Okay. If there aren't any other comments or questions from anybody, I think we'll let Sharon carry on walking wherever she's going. Thank you for bringing that to our attention. I'd say we'll put that in the faculty newsletter and let people get in touch with you individually.
That's amazing. Thank you for giving me a chance to present. Thank you.
Not at all. You're very welcome. Thank you. Okay, again, we'll move on. So we'll have the updates from the faculty subgroups now. So most of these have come in printed form. So Sophie from Pathway has kindly given me a summary of the mental health network, the lived experience network, and I've also had something from Samraj Buller about the student faculty. So I'll just quickly run through those. So from the mental health network, the network has continued to grow in membership, and quarterly meetings have been dynamic and well attended. The meetings are chaired by Jenny Drife, consultant psychiatrist in the START team in SLAM. Have been a mixture of presentations about research, services, and hot topic discussions. At the most recent meeting, we heard from John Pritchard, Associate Director of Housing and Community Inclusion at Southern Health NHS Foundation Trust. He presented about his unique role and the impact this has had on integrating housing with mental health services. We also heard from Alistair Churchard, a course tutor and clinical psychologist at the Oxford Institute of Clinical Psychology Training and Research, on the connection between autism and homelessness. The hot topic discussion and mental health priorities. Current research mapping was led by Pathway's Theo Jackson, research and data analyst. The next network meeting will be on Tuesday, the 4th of July at 10 till 12. If you'd like to contribute or join the network, please join through Pathway's website or contact Sophie at Pathway. Theo, I think you're on the meeting. I don't know if you want to add anything to that in terms of what the meeting was like that you attended. Maybe he's not with us now. He was here earlier, but maybe he's had to go. Okay. So that's the mental health network. And then we've got Jeff here as well from the lived experience group. So I'll read this out, Jeff, and you can add anything. So the lived experience group members continue to have an active presence across multiple and various arenas. Despite the group's small size, we strive to ensure lived experience is involved in every aspect of our work at Pathway, including reviewing the lived experience programme itself. Group members have been involved in co-delivering training to Pathway teams and at the BSMS, the Brighton and Sussex Medical School, continuing professional development days, supporting research projects and attending the faculty specialist sections. The group worked with Caroline Schulman and CJ Barton to make the film Less, a film about personal journeys to help from people who've experienced and overcome homelessness. They've also been involved in developing the e-learning module on Fairhealth on supporting people who are experiencing homelessness in A&E settings. The group's active involvement in all aspects of the conference, including being part of the steering group, is a highlight for many. Pathway's policy team have worked closely with the lived experience group members to co-write responses to government select committees and papers. In order for the group to continue to develop, we're currently in the process of recruiting a new full-time lived experience program manager who will continue to work alongside Sophie to ensure the voices of people experiencing homelessness is central to everything we do. So, Jeff.
All I would say is she's pretty much got it spot on. I mean, that's it.
Great.
Let's be honest. The bonus is, the big bonus, the big difference is that we're actually more involved with Pathway as an organisation than anybody else. There's lots of organisations out there that I work with, but nothing to the degree that we do with Pathway. You guys involve us in so much more. I mean, Alex was complaining at the conference. He was doing 5 sessions at the conference, and I did 6. Yeah. But for somebody with lived experience to be doing 6 sessions, to chair sessions, to present sessions, to give Stephen Powers a bit of a mouthful, you know, you don't really get those opportunities with anybody else. So long may it continue. I can only applaud Pathway for the fact that they work with people with lived experience as much as they do.
Great. Okay. Thank you.
Thank you, Jeff. I was just going to say, Chris, just to chip in, and also we've just succeeded. Some colleagues will. There's a guy called Lord Victor Adebwale, who's a bit of an ally of Pathway at Times, who had promised at the launch of the film Les that he would make it, that we would get to show the film again, which opened the conference at the NHS Confederation Expo, which is coming up in Manchester in mid-June. And we were a bit worried, but he's actually honoured his promise, and we are going to have a viewing of the film in conversation in a platform session chaired by the Channel 4 News health editor, with Jeff and colleagues there to talk about the film with an audience at NHS Expo. So we keep going. I did get the figures, Jeff, the other day. I think it's had, I'm not going to make it up, but the website's having quite a lot of visits. I can't remember them.
Wonderful. Sam Pratt, who I'm sure a lot of you know, Shared Health. They're showing the film. Me and Mandy are going down in June again to Manchester because Shared Health are doing it. A Doctor Deprivation Day. Sounds terrible, but there you go. Trainee doctors mostly who are about to work in areas of high deprivation, so they're going to show it as well, and we're going to go down and do a Q&A.
Fantastic. Cool. Great. Thanks, everybody. And then a short update from the student faculty. So this is from Samraj Buller, who's one of the coordinators of the student section. He said, would you be able to pass on a huge thank you to the faculty for their support this past year, and a little summary of our work below. So there have been 3 webinars, online learning resources for inclusion health, street services, health needs of sex worker patients. The team have also begun plans for the development of an inclusion health report card, so that particularly medical schools can sort of self-assess as to how they're doing in terms of including inclusion health in their curriculum. They've begun to build the UK Inclusion Health Directory, so that's a directory of all the student societies, the specialist services, the research departments and charities. So that's so people can get in touch with each other, and particularly so that students can ask if they need to do a period of study, an elective period of study somewhere, they'll know who to contact. And they've also created their social media accounts. They've got a Twitter account and an Instagram, and I have the addresses here if people want those. I'll cut and paste those into the chat in a sec. We've also got the primary care network, which again has been meeting regularly. So we have a national network of clinicians working in primary care and inclusion health, which meets every 3 months, and then regional groups which also meet every 3 months. So we've divided the country up into regions, and people are leading on each region. So we've had meetings about the difficulties or the challenges or responses to improving screening and vaccination programs. We've had people talking about their services, so the various services around the country. And I think every time we have one, we find out about new services are working with people in the inclusion health groups. So that's a sort of building, growing network. A lot of those people came to the conference as well, and it was great to be able to meet people in person. So we're planning to obviously continue to grow and develop those networks over the next year or 2. Anything anybody wants to say about the faculty subgroups? Good or bad, we can take it.
Again, one other thing, Chris, occurs to me that Sophie, who's not here, is trying to form and has had a couple of specialist OT meetings, and there's a growing occupational therapist working in inclusion health network, which again, if people are interested in connecting with that, it's drop us an email and we can connect any OTs out there who want to meet their colleagues who work in our terrain. That's beginning to come together, and they're beginning to think about sharing practice and yeah, supporting each other.
Great, thank you. And I'm just sending the Twitter and Instagram. Are they handles? I don't know, addresses, handles, whatever they're called, in the chat there for people to see. Okay, so we'll move on to the next item, which is about the NICE guideline. So just by way of introduction, just in case people don't know, a NICE guideline, integrated health and social care for people experiencing homelessness, was published in March 22. So it came out the week of the conference, and we had sessions on it at the conference in 22. Things haven't progressed very quickly since then, I think it's fair to say. So recently, Pathway and others have been working with Dr. Catherine Hamilton, who's a public health registrar currently in the Inclusion Health team at the Office for Health Improvement and Disparities, OHID. So she has been doing some work. So she's been to local authorities around the country, first of all doing a questionnaire and then doing focus groups. So one in the northwest, one in the northeast, Yorkshire and Humber, one in London and the southeast, and one in Midlands and the southwest. And so she's been doing quite a lot of work on this, trying to find out exactly how much the guidelines have been implemented, what's the awareness of the guideline even. So her conclusions from her work have been that there's limited awareness of the NICE guidance and lack of clarity as to how it fits in with statutory regulation and legislation, which I think probably chimes with people's experience on the ground. There's little correlation between the population size, the numbers of rough sleepers, the proportion of homeless households, and the integration of commissioning and multidisciplinary teams. So where things are happening, it's not necessarily in the places with the highest need. There's good interagency working in some places, but this doesn't turn into strategic changes to systems to improve access for people experiencing homelessness. Longer term, more sustainable funding, improved evidence base, and direction from senior leaders at local, regional, and national level were all identified as necessary drivers to increase integrated commissioning. On a positive note, there was a willingness noted to keep improving the system and share learning through formal and informal structures. So I think that's kind of a long way of saying lots of people don't know about the guidance, and where they do know about it, it's not being implemented in any sort of systematic way, and where it is being implemented, it's not necessarily in the areas where it's most needed. So I thought it might be worth just hearing from people about whether they're aware of the guidance, whether they're aware of any local initiatives to implement the guidance, how far they think they are in terms of bringing in the things that that the guidance says should be done, which are things like having homeless specialist services, having homeless MDTs, having intermediate care facilities for people experiencing homelessness for when they come out of hospital. Those should be commissioned. I don't know, Rachel, were you aware of it? Obviously, because you're doing a lot of development work, have you based some of that on the NICE guidance?
Yeah, definitely. It's like I say, I think it's just the awareness, especially across the clinical setting. It's difficult to, link in, I suppose, with some of the consultants. I don't know whether it's because it's a stigma thing or what, but I feel as if there probably needs to be a little bit more clout, I think, because obviously I'm, an AMP at the end of the day. So I am, like I say, I've got a good relationship with one of the consultants down there, but I think it's getting in with probably the more senior people and leading it from the top down. But the awareness side, yeah, it's not a lot of people know about the guidelines at all.
Sure. And I can see there's a question in the chat from Margaret Greenfields. Is this information about the guidance available yet in a directly accessible report? And the answer is no. In terms of the work that's being done by Catherine, it's not published yet, and she asked me only to share those high-level conclusions because obviously they will be publishing later. Any other questions, or what about other people? Other people are aware of the guidance? No, we don't know when it's going to be published, but I can find out from Catherine and let you know.
Thank you.
From other people, are other people aware of the guidance, whether it's being implemented in their area, or to what extent? Sort of do the findings that Catherine's published, ring true?
So my name's Ishbel. I'm a GP up in Edinburgh.
Hi, nice to meet you.
Hi, nice to meet you. I work for the Access Place in Edinburgh. So it is sort of an integrated service with housing, social work, and health. We do have some of these things. We've got hospital inreach, outreach, step down intermediary care and stuff. But I think it's quite difficult, isn't it? The funding comes from the Edinburgh Health and Social Care Partnership, and you have the funding, it's got to go a long way. Sort of out of a primary care pot, but you end up sort of doing, sort of almost specialist addictions, specialist mental health. There's not really enough to go around. So that's the difficulty we're having, is making it go all the way. It's quite tricky. And although the Edinburgh Health and Social Care sort of is aligned with the vision is aligned, I guess, with the NICE guidelines, and that it's been more flexible, but we've met some barriers. The council IT system isn't compatible with the NHS. So we've got things like separate check-ins and separate computers, printers. It's quite, there are some challenges. In Scotland as well, just in general, it's been a real shame. The Glasgow Homeless Service has been in the news, and that's shut, and that's such a shame, because obviously one of the writers of the NICE guidelines worked for that service. So it's really just feels a bit unpredictable as to which way. It's all sort of locally driven, isn't it, with unique services.
Yeah, I mean, I think we often hear from services that they funding is always sort of short term. It's sometimes what's been left over from other pots of funding. It's not for very long, and often doesn't cover all the things that need to be done, as you're saying, that you just stretch it across.
It's difficult. It's interesting hearing from yourself, Rachel, that you got all this funding sort of from all these different people, and a lot of it was sort of central council. We've been doing it the other way, sort of trying to get the third sector agencies to do projects in that. And I find that really interesting, isn't it? It's a lot for an operational, I don't know, I'd be interested to know this in your practice, but it's a lot for one operational manager in integrated health, social and housing, with no sort of HR department, and no departments like you have in some of these bigger charities to be well versed in application bids and funding and how to write them, and managing all these HR of all these different people. Yeah, it's a lot of challenges, isn't there?
Yeah, and I think that's part of the approach of the guidelines, isn't it, to try and get those people together, because you need social care and health and the addiction services and mental health all working together around people in order to get the best outcomes, but they traditionally work separately. So I think that's part of why the guideline has been designed as it is. Okay, we'll bring in a few more people. So Peter?
Yeah, I was going to say, in where I work in Tower Hamlets in London, I mean, in some ways, we're better than a lot of other areas in terms of alignment with the NICE guidelines. But I think one of the problems is that at the moment, ICBs and ICSs are really just kind of rolled over from CCGs, which means that they're fragmented. So you've got different bits of what's supposed to be an integrated care system, and sort of managing different bits of homeless and inclusion health. And often each of the bits aren't necessarily terribly aware of what the others do. And that's certainly true where I am. The homeless GP practice has a different set of commissioners to the pathway team, which has a different set of commissioners again to the outreach service for homeless and vulnerable migrants. So I think there's a lot of work to do in sort of making or helping ICBs and ICSs do kind of what they're meant to do with the integration bit, I think. So I think that's one of the gaps at the moment I can see. And I don't know how aware commissioners are of the NICE guidelines. I mean, hopefully they are, but don't know.
I see Jeff's put in the chat that guidance can be ignored, which is part of the, I guess that is part of it, isn't it? If it's not being assessed, if it's not being, you know, CQC aren't judging against the guideline, then there isn't that much incentive for people to comply with it, or they may have other priorities that they want to look at first before coming to the guideline.
Perhaps, Chris, just to offer some feedback from the work, some of it was presented at the conference. We did a project over the last 6 months with 6/7 integrated care systems. So Fishburne from Scottish colleagues, our new marvellously next round of NHS England reorganisation, the new structures, integrated care systems. And we recruited quite senior people from 7 of them to do a 3-month learning program with us on commissioning good inclusion health services. They weren't top senior people, but quite senior people, and they were all really were feeding back to say that the commissioning system in England is still in complete chaos and meltdown, and they don't know which way is up, don't know what their jobs are, and they don't know whether they're going to have jobs next year. So, and further, what they were interested in from the program ultimately was really ammunition, in the sense of things they could use to make arguments to get bits of money aligned on the needs of our population. And the NICE guidance was helpful, but they also wanted other kind of, it wasn't perfect, and they needed other ideas as to how to get the board and the senior people to give them the time of day, as it were, to even give them a 10-minute slot on a senior agenda to try and get some attention. So we worked with them quite a lot on different tactics and different arguments, and the film we referenced, some hearts and minds you need, and trying to maybe shame people or terrify people, or what kind of, there are all kinds of tactics to try and get busy senior people to listen. We'll be publishing a report of that shortly. What's nice about that work in a way is that it seems that this isn't a done deal at all, that maybe NHS England might be giving us a small amount of money to repeat that and work with another 7. And we're going to try and roll together a group of good, quote, good commissioners. I mean, they are good people, as it were. They're just, that's the jobs they have, and trying to get them to begin to support each other and almost get them to give each other permission to do the right thing, because they're often seeking permission to act somehow, but as they don't know where the power is in their organisation, and keep saying that nobody seems to, it's a kind of circular. I don't know if I can even ask for this. I don't know whose agenda to put it on, and I don't know where to take the funding ask when I do get permission, because nobody's quite clear whose budget is whose. So just a picture of a system in quite a lot of chaos at the moment. But hopefully in the next period it must calm down a bit, I think.
Thanks, Alex. Any thoughts from anybody else? Is anybody working in an area where the guidelines just not being used, or there's nobody's aware of it in the commissioning side? No. Or any areas where people think, no, it's being followed closely and is really guiding the work that the commissioners are doing, or that they're doing clinically? Okay. I think nobody wants to talk about the NICE guideline anymore. Okay, that's fine. Well, thank you. Thanks for those people who contributed. That's really useful, and I can feed that. Back. I mean, I think what we're really saying is that those conclusions probably are quite accurate, that it's very variable and patchy as to where it's been implemented, and awareness generally is quite low. So I guess we've all got a job to try and promote that around the place. Okay, we will move on. So the next item is conference feedback and ideas. So I think, Alex, you were going to talk about this.
Yeah, thank you, Chris. And if we were in the, it's funny, these online things, if we were in the room, I'd ask people to put their hands up and say who came to the conference or who's seen it. But I think some people I can see were at the conference. Some people I think weren't. That was our 12th conference we've run. Feedback we've had has been that it was very, very nice to be back in the room properly. People really appreciated coming together. We asked people to fill in a feedback form. Again, feedback forms from events are interesting because our partners who put the event on with us always say that you get the people who fill in a feedback form in the conference are the people who have something to say. There's a big group of people who are too busy and don't. But so you either get the very angry people who didn't like the lunch, or you get the happy people, as it were. And what we've got from our conference is basically the people who filled in the forms, of whom there were 55, just got in front of me, generally thought it was absolutely fantastic, which is really nice. I think we often get that in that what they're really saying is that they think their colleagues are fantastic because the event creates a place for everyone to come together and meet each other. And what they're really saying is it's incredibly empowering and uplifting to spend a couple of days together with people who see the world in the way that we do, I guess, as a collective. And people take a lot of solidarity from realizing they're not alone. So in terms of feedback, again, colleagues who work in other services, when you get lots of, so they're offered to score from 1 is not very good to 5 very good. I think we've got 40 very goods and the rest are goods, which doesn't really help you spot where to make things better, which is the way you're supposed to use feedback. So really lovely. I think, again, for colleagues who weren't there, the materials are all online, which is what we do. So the whole thing is recorded in a box set, is available for people to use afterwards. Again, we're seeing that being used quite well. We did get a bit of off feedback, which were delegates who weren't there. We put in place what we called hubs. So there was a viewing hub in Manchester. You could go to a venue in Manchester, not come to the venue in London, and get a cup of coffee and sit and view the thing online and ask questions online. We also had one of those in Leeds. In the past, we've had similar venues in Scotland and in Ireland at times. One of those went quite well and the other one didn't go so well. The one which went well, I think this right, is in Leeds. We had a really nice colleague who hosted it, who was there in Leeds and said welcome and was kind of comparing. The one in Manchester was much more like just going into a room and it came on a screen and people found it a bit flat. So we'll be thinking about how to maybe make those nicer experiences and really trying to get a local host for them. Again, what we used to have some years ago, colleagues in Scotland used to take the keynote speeches and the bits they liked basically from the conference and run their own event 2 weeks afterwards, but just drop it using the recordings to drop in to a local event, which again is another way for people to use the content, which again is people are interested in thinking of other ways to spin it off, then do come back to us. So the purpose for today really is to say the trouble with running conferences is that as soon as you've done one, you have to start again. And the lead time is long. The routine to build, the other thing to report is actually we had the largest number of registered delegates we've ever had. So we had, I think it was 450 or so, and that's the biggest number we've ever had. And that's really great. And it shows we're kind of finding the right people, I think. But we're also aware there were lots of other people who weren't there. So the other thing to feedback is how we fund the conference. The conference is, I guess the best way to describe it is kind of crowd-funded. So Pathway as a charity puts some money in up front, which means that the 65 speakers don't have to pay and get a free lunch. It also means that we have places as part of their subscriptions, Pathway teams all get 4 or 8 tickets for team members, which is another set of people who are there they've not paid, we've paid, but they pay us for the support we give them. So money is washed around to try and create the room. We then are quite dependent on ticket sales for some. We then also have some other free, quotes, free places. They're not free in the sense that somebody else is paying for the tickets. So we try to do our best. This year, again, we had some sponsorship. So there was a company name, there's a drug company who got sponsorship, who are manufacturing one of the new, I'm blanking the name. It's one of the new depot injections. It's
the buprenorphine.
It's a
depot
buprenorphine
injection.
people who seem to kind of appropriate sponsors. Yeah, Buvidal, that's right. Any of that income which comes in allows us either to have more people in the room who aren't paying, or to subsidize down tickets for people who haven't got any money. So we try and do that each year. We'll be doing again the same this year. So the key thing for this evening really is to say we're going again. We really like the venue. We think we're going to stay with that venue in London for next year. The year before, we took it to Manchester and London one day each, and that nearly killed some of us involved in that experience. So I think we'll stay in London for next year, but maybe go out of London the year after. The time now then is we're looking for volunteers who would like to join our conference steering committee. So again, you don't have to put your hand up now, but if you're interested very seriously, please do get in touch. We usually have a group of about 14, 16 people, try to have a mixture of clinical disciplines, mixture of experiences, people who lived experience too, always present. The tasks there are to help us work out what it should be about, what the core themes should be, identify keynote speakers and headline speakers that people would like to hear from, or conversely, people would like to put on the spot, because we have a platform. The intention is to use it as a platform in terms of power. So we can. So for example, one of the ideas is that we will try and invite Wes Streeting, the Shadow Secretary of State for Health, to see if we can get Labour, it will be close to a general election, to come and tell us what they're going to do. And even if they don't come, firing an invitation into them is a place for us to say, what about us? What about our issues? Are you thinking about it? So it's a real, we've built a platform. We've built a bit of a movement. In the feedback, people were saying they felt really like we've got some momentum here. So let's use it. However, across a 2-day platform, you only have 8 speaking slots on the main stage, maybe 10. So you can't have everybody. So what should be the themes? Who are the keynote speakers? But we need to think quite soon about some of those things. It may seem March next year may seem a long time away, but it comes frighteningly fast. So that's the task. The other thing which happens before the summer, we will put out a call for papers. So we put out an open call to the faculty email list and in other places too, inviting submissions of projects, things, experiences, anything, free form, whatever, anyone people want to bring to them, which they think their peers would benefit from or like to hear about. Part of the role of the steering group is to read, review, and assess all of that material and work out what makes the cut, and work out how it fits together to try and make a coherent program, which is always a challenge. So that we usually put that out before the summer, ask for submissions by September, and try and have a confirmed program by mid-October in terms of workshops. So that's the shape of it. And then the steering group are helping us just endlessly work out, to include this one or that one. Who do you think is better? Or should we ask those 2 lovely people to try and do their thing together? A couple of other bits of feedback. We had some Petra Kucha sessions this year for people who were there. Delegates thought they were fab and would like us to do them again. Delegates also thought we should have more space. Trouble is that people always want more of everything. Delegates wanted more space just to talk to each other. I remember some years ago someone saying, I love the speakers, but really what I come for is the chat. But my manager would never let me say I want to go for a 2-day chat convention. So make sure there are some good speakers which sound credible, such that I can justify the ticket, but make sure there's enough time for people to talk, so that balance is always a thing to think about as we're programming it. So I welcome take any key themes now if people have got ideas of areas they really think we should focus on, and or again, we're on kind of on receive. And again, if you would be interested in joining a steering group, I can't say you're definitely on it tonight, but if you want to send me expression of interest, as I say, we're trying to create a balanced group which represents broadly our world. So if you're interested, please do. It's about a meeting a month, particularly in the autumn, effectively from now through to next March, with a gap in the summer.
So there's some very positive comments in the chat, particularly around the food, which everyone agrees was really good. And also people saying, so Denver, Donnock has said they would be happy to join the steering group. So there's people putting their hands up already.
Great.
And Margaret's saying, can we have a theme about curricula and effective teaching?
Interesting. The various people in other work we're doing, people saying we should do more to really focus on education as a theme, and how to get our knowledge and how to teach more, how to share more. So that's an interesting idea. Thank you.
And Jeff said he would join the steering group again.
Great.
So it was good to have somebody with a big mouth there.
Yeah. Any ideas? So themes. So one of the themes we think is probably still around us is integrated care, and where, I mean, there may be a very political theme if we're close to the election and if we're trying to get some political traction. One of the themes are still around, I think, will be what integration means, and are we really seeing services joined up? A couple of other ideas just to float is that some other colleagues have been saying we haven't ever, again, the call for papers, we can put some subjects in that say we're particularly looking for papers on item X this year. One of the suggestions which has come in through other networks is actually around the theme of violence, which we've never focused on, but it's very much, unfortunately, is a thread which runs through a lot of people's experiences in our world and people's lives, and perhaps it's something we should spend some time thinking about together. So that's just one example. And then again, Rachel, thinking about your issues, we haven't had there wasn't a big focus this year on addictions and on substance misuse. There was some content, but less than there has been in previous years, and whether there should be more in that space.
Okay, thank you, Alex. Time is moving on, so I think if people do want to volunteer or have any ideas about themes, either put that in the chat or contact us afterwards with your ideas. So the next thing is the members survey.
Yeah, I think that's me as well.
Yeah,
that builds on the same thing. Again, colleagues who were there may have seen Matt Downey present, and actually that's interesting. He was very, very moved by his session at the conference, particularly the closing, and also the closing plenary, where we agreed that everyone was feeling very, very, very pissed off. Indeed, quite a lot of anger in the room, really, but quite a lot of discussion about, and afterwards, how do we focus that and try and change some things and use that. So one of the things we're doing, back to we've created this thing called the Faculty for Understanding Inclusion Health. We've created a conference, we've created a website, we've got a platform. Let's try and harness some of that and direct it. One of the things we want to do to work out which direction to head in is to do a survey, which we've never done in a robust way, of the whole faculty members. For colleagues on the call, there are about, I think, 1,600 people on our email list, mainly in the UK, but some spread around the world as well. So we have been working within Pathway to frame a survey of all the members of the faculty. One, to find out who you all are, what you're all interested in, where you are, what kind of services you work in, and then perhaps for this political point, what you think the grinding or most important issues are that face us at the moment. So that, which is, if you like, one level standard lobbying. You will have seen the Royal College of Emergency Medicine put things out quite recently, say we've surveyed our members and they say these are the big problems in A&E. It's to generate that kind of material, because we think we've now got sufficient credibility to begin to say this is what people working in specialist homeless and inclusion health services say are the problems, and we can use that to try and get some attention, get some focus on our issues. So we've spent quite a lot of time trying to design and work out what the questions we should ask are. We've had 1,722 on the email list. The emails we send out, again, we know that we have a very, relative to other direct mail lists, we have a very, very high rate of engagement with faculty emails. I think it's something like 30% of people open an email from us, and that's not so that's high for these kind of things. So it's a very engaged network. So in a way, this is just an early alert that we will be issuing this survey. We have a commitment with Crisis, our partner, the National Homeless Charity, for the survey to be published as findings in an annual, I think we're going to call it an Annals of Homeless and Inclusion Health, so an annual publication which tries to summarize what we know about the state of the world in our world. So again, for example, I was just thinking, Rachel, if monkey dust was coming up as a particular theme, we might try and spotlight that as a kind of cause for concern coming up from the front line. This is really worrying. We shine a light on that and use that to drive attention on an issue. Use the faculty, the survey of members, similarly to work out what to talk about, because we don't know. It's up to what people tell us should be the priorities. But so what I want to say is, when it lands in your inbox, please fill it in. Classically, there will be a question in it about what it should be like and whether we've got it right and whether there are other topics or themes we should have included, but we haven't. So please, it's the first time we've done it. So we're really looking for feedback on it as well, because the intention now is to do it every year, which will allow us also to begin to build a trend of how people are feeling, what's going on. For people involved in services, we'll be asking you how you feel, literally, how you feel about money and funding, how you feel about the survivability of your service. So we're trying to make it a bit of a barometer for what's going on out there. I'm not quite sure when. We're fairly close, so it will come out as a SurveyMonkey thing, and we've ummed and ahed about what's a reasonable amount of time to see if we could ask people. I think we're hoping it would be completable. If there's anyone else on the call who could help me, I think we've thought no more than 20 minutes, but it's maybe a bit less, but it's not a 3-minute survey. We are asking for some consideration and some considered responses if possible.
Yeah, I think that's about right. We thought it was sort of 20-25 minutes. Okay, I'm conscious that time is moving on, so we'll move on to our last item, which is about the pathway stroke shared health A&E online training. I think, Alex, you can talk about that as well.
I think I've talked too much. I think we put it in the chat, so really delighted. Sam Dorney-Smith, our nursing fellows, who's just gone on 4-month sabbatical, working with a set of colleagues over the last 6 months, including Royal College of Emergency Medicine, Shared Health Foundation, Jeff and our Experts by Experience group, several other clinical colleagues across the country, has produced a really interesting and useful training resource, which is in the chat. It's targeting A&E colleagues particularly. It's particularly focused on issues of self-neglect, mental capacity, and self-discharge around A&E, and aiming to help A&E colleagues perhaps rethink what may be going on for someone when they are leaving the department, and when you may not have really thought through what might be going on underneath, and that actually you do have some things in the Mental Capacity Act, for example, that you can use in the safeguarding regime. So it's on the Shared Health platform, which is really nice. It's in bite-sized chunks, but it is a learning program. So I think that each module is kind of 20 minutes. There's some video content, there's some kind of PowerPoint factual content, and then there's sometimes a kind of check questionnaire to say, have you reflected on the learning? For colleagues on the call, we also see it as an asset that you can use to take to your A&E colleagues and say, oh, look, this is really useful resource. Why don't you use this? Have you learnt? And perhaps if you go through it yourself, you could use it as a training resource or as something to get you into conversations with A&E colleagues, because it's designed for them, but they may need some little encouragement to realise that it would help them. Again, we think it's both bite-sized chunks, and it's really practical actually. So some very basic fundamental things which we think will help A&E colleagues do a bit better. So it's there. As perhaps we should repost it in the chat. But yeah, it's a new resource, so please make use of it. And again, feedback welcome.
Great, thank you. Okay, so we have 4 minutes in case anybody has anything they're desperate to say, or any comments on anything that we've spoken about this evening. Peter's asking about the link. I wonder if Jonathan could put the link into the chat for us to the A&E training. Thank you. Yeah, so open 3 minutes basically. Anybody got anything they want to tell us about or ask us about?
Just quickly, what I put in the chat, it occurred to me that possibly for the conference, having some sort of session with ICB leads looking at how to improve integrated care for inclusion health populations and implement the NICE guidelines might be a good way to engage them.
Yep. And we'll have our cohort who finished the ICB work this year. So perhaps we could get them to come and talk about the progress they've made and how that's been. I think that'd be really good.
One other idea on the conference is a proposal that we should actually plan to issue a communique, as it were, at the end of the second day. So we say that kind of we, the gathered members of the Faculty of Homelessness and Inclusion Health, hereby assert that 2 days we've agreed the following, and here's our programme, as it were. In order to do that, we need some kind of working group beforehand to work out what we want to put out there as a kind of strong statement. Particularly if we could get the Shadow Secretary of State on the platform, we could then give it to him and say, here you go, this is the programme, what are you going to do with it? But that takes a bit of work to produce those things.
Chris,
Okay.
can I ask?
Yes.
Chris? Oh, sorry, I missed the beginning. Are you going to? How often are you going to have these? And are they? Is it always going to be a Monday? And is it?
These meetings.
Sort of general approach to them.
I think we'll try and vary the day to allow different people to attend. I think we used to have them 3 times a year previously, something like that, either quarterly or 3 times a year, so every few months.
Yeah, and
is that
so it's just to network all of us working in homelessness mainly, is it? It's not just for people working in Pathway.
No, it's for everybody in the faculty, and anybody can join the faculty. So anybody interested in homeless and inclusion health can join. So spread the word, tell everybody. Is there a day? Is there a reason you ask, Shanti? Is Monday difficult?
Yeah, it's hard Mondays and cooking dinner and childcare stuff. So I can listen in, but probably if it was a day where I did, had childcare covered, I'd quite like to come in person. If you do a mixed thing at any point. Yeah,
sure. We have done in-person meetings like this in the past, so perhaps we could do some sort of hybrid thing, so people can come and meet each other. That's a good point. Thank you.
Okay, thank you.
Okay, let's close the meeting there then. So thanks to everybody who's attended, and thanks to everybody who presented. And we will put out a date. We'll give a bit more notice next time, and put out some dates perhaps for the next year as to when they're going to be, and we'll vary the day. We usually keep it this time so people can come after they've finished work. I know that's not ideal for everybody, as you say, Shlanti, if you've got childcare commitments, but early evening seems to be the time that works best for most people. Okay, thanks everybody. Enjoy the rest of your evening, and we'll see you all soon.
Bye. Thank you.
Good to see you.
Bye.